Can you see my screen?
Yes, please.
Great. So thank you very much, Dr. Muhammad, and for this lovely platform, and to Alamera. It's great to be on this symposium with Vishali, who is a good friend, and with Ahmed, who we trained together in Moorfeilds many years ago. So I, fantastic cases by everyone. All these mysteries and exotic things. So I'm going to be a bit more straightforward. My cases are fairly simple, but I just wanted to share my experience of using Iluvian with in cases of non-infectious uveitis. So I've got three quick small cases. And I'd like to see what everybody else's experience has been with Iluvian and how it can be a useful tool. So, Iluvian is the fluocinolone implant, 0.19 milligrams. It's sustained release over 3 years, not biodegradable. It offers some relief from repeated injection of shorter acting steroids, which we've been doing for much longer. Whether that's triamcinolone or Ozdex, both which I use extensively. And it also may help with the long-term control of uveitis. There are some assumptions or some or some things that we all think about Iluvian because it's a slow release, low dose drug eluting. It does take a long time to work, and so people are worried that it may not work in quickly enough. A lot of people do say that it does not work for severe cases. And one assumption that I've heard in many of these sort of webinars recently was that it works in only cases where the steroid implants last for a long time, and so that's assuming that there's a low inflammatory drive rather than a high inflammatory drive. So I just thought I'd share a few of my recent cases and see what you think about it. So this first case is a 34-year-old lady who presented to me in 2015 and she said, "Oh, I have a history of uveitis and was treated with steroids only for several years, and she had cataract surgery elsewhere. And she had very poor vision, 660 in the right eye and 624 in the left eye. She was on about 40 milligrams of prednisolone monotherapy for the last 2 years. And you can see that, she's got this very extensive amount of multifocal lesions, and she had sort of pan uveitis picture. So I could say that, she was undertreated. She had a lot of systemic complications, Cushingoid, she had secondary diabetes. It's a young lady. And, the differential here, of course, would be VKH, especially in this region, Middle East. But for somebody who was undertreated for several years, she didn't have any of the other systemic manifestations except for the sunset glow type fundus. And so, we were treating her as a MSCPU. So I started her on systemic immunosuppression with mycophenolate Moorfeilds, and she responded very well. So this was after about 3 months. You can see the horror picture much better, and it had cleared, and she was doing much better. She was now 618 in the right eye, 618 in the left eye. And she was thrilled. So the patient was very happy. I was very happy, and this was great. Of course, the next thing she says that now that my eyes are sorted, I want to have a baby, and I want to stop my systemic medication. And I was thinking, oh, hold on, for 8 years you've been, for years you've been undertreated. We finally got you to a place where it's comfortable, and now you want to stop your treatment. And she was adamant. So she said, look, I'm going to stop treatment. You do what you want. You have to manage. So I had to wean her off the mycophenolate, wait for 6 months before she can try to conceive, and we went to plan B, which was repeated Ozdex injection. So this was her about free Ozzydex. This was in 2016 in March, and then she had the Ozzydex, and then in the right eye she had 4 Ozzydex injections in the next sort of year and a bit, and she had fortunately managed to get pregnant, IVF, and had a baby. And this is the left eye. This was her better eye, which was, and every time the Ozzydex would wear off, we would give her another Ozzydex, and she had 4 or 5, and this went on. So, she was treated successfully with systemic treatment, but then it went on that the Ozzydex would last for only 2 months. And so I advised her to that we should perhaps try Iluvian, and this was at the time not covered by the insurance in Dubai, but in Abu Dhabi it was covered. So my dear friend Igor Kozak, who's at Moorfeilds in Abu Dhabi, very kindly agreed to treat her with the Iluvian, and so the next few images are courtesy of Dr. Igor, who I know, who very kindly shared these with me. So this was her eye. So she's off all treatment. This is in September 2018, and this is pre-Iluvian. And so she had the Iluvian a little while after that, and this is her 6 months later. And this is only on Iluvian, and from what I understand, even until now, she's not needed any further treatment. This is the right eye. This is the left eye pre-Iluvian, and her vision is maintained. She's not required any other treatment. This is the right eye. You can see all the visual haze has cleared, and similar in the left eye. So this, you can see very severe case of multifocal choroiditis and fan uveitis, treated successfully with mycophenolate, but wanted local therapy. Needed 2 monthly Ozzydex for 3 years or so, and so she had several injections. And then in December 2018 was given a bilateral Iluvian, one after the other, and has now been flare-free for more than a year. So it sort of illustrates the long-term control of inflammation in these patients of non-infectious uveitis. So any comments at this stage?
Dr. Vishali, do you have any experience with using Iluvian in treatment of uveitis?
We have used a lot with diabetic macular edema. It works. I mean, and it's a long-term solution. I would be very happy to use it for uveitis the day it comes in India. I do a lot of local, like we use about 200 Ozzydex implant a year, so I would be very happy using this.
Dr. Ahmed, I think you have more experience because in United States, I think it's available long time.
Yes, so it's available in the United States. It's available under Iluvian for diabetic macular edema, under UTIC, name UTIC for uveitis. It's just a different injector, very similar molecule. I think it's a very good medication. I still do Retisers for severe cases, so I suture Retisers as well.
I mean, they get FDA approved for uveitis since when?
Since I think it's available now for nearly 9 months.
So in the US, I think it's different.
Do you have a chance?
The parent company has sold the rights of the uveitis to another country, and it's marketed as UTIC.
Yes.
Whereas here for uveitis, the rest of the world, Alimera Sciences distributes it for diabetes and for uveitis under the name of Iluvian, and it has been licensed in Europe and in our region for uveitis as well. And so, I'll just show you another case. Now, this guy, a 30-year-old chap from Pakistan, presents with, he came to me with reduced vision and floaters. This was again 2 or 3 years ago. And you can see he's got this typical, somebody who's talking about Eels-like disease, but it's this vasculitis. He's got this periphlebitis, occlusive vasculitis, um, and quite sort of dramatic picture. And his quantiferon gold was positive, being from the subcontinent, widespread vasculitis, periphlebitis. So then he's treated with anti-TB treatment and steroids, and then put him on mycophenolate and lasered all the areas of non-perfusion. But you can see there is, he had these sort of vein occlusion type pictures, also with a lot of macular edema, and in the right eye. And if you see the right eye here, this was about this was in July of 2018. And then, he kept recurring. He kept getting this macular edema. I had given him some anti-VEGF at the beginning because of the occlusive disease, but his macular edema kept on coming back, and he kept having Ozurdex injections, and he responded very well to the Ozurdex injection. So this is him 3 months after that. His insurance, and so this was him at the time. He's been lasered to the hilt, and but he just kept on getting the macular edema. So at this point, he sort of moved across to another facility because his insurance was no longer covered with us, and he had another 8 Ozurdex injections over the next 2 years at another facility. Then he came back to me in February this year, and again with this macular edema, and he noticed it had fallen. He had an Ozurdex injection about 3 months prior to that at the other facility. And so I said, okay, we've had so many, let's try with Iluvian. And so I gave him an Iluvian. And this is him, literally a month later. So I had prepped him at the time, saying, look, Iluvian will take a long time. Maybe we'll have to give you an Ozurdex top-up or this or that. But literally a month later, he was much better. And I saw him just last week, and his macula still remains dry. So, that was pleasing to see. That this sort of patient who's had to have several Ozurdex again, Iluvian can work pretty quickly. So this was another point that people always argue that Iluvian takes a long time, and I was quite surprised in this case that it worked pretty quickly for his uveitic macular edema. Now I don't know if you agree with the treatment or the management there, especially with these sort of TB type patients.
Yeah, I would agree. It's done. It's worked for your patient.
And he had stopped his mycophenolate because again his insurance company was not covering. And maybe if he had stayed on systemic treatment, he may not have recurred as often. But again, if the Iluvian keeps him under control and he doesn't get any fresh inflammation, then that might spare him from long-term systemic immunosuppression.
Right.
Do you get to see some of these patients, Ahmed, in Arkansas? I know
Which
there's
patients?
a lot of...
Which patients? Which patients, Abby? TB-delayed hypersensitivity uveitis? Or?
Yeah.
Yeah, we see lots of infection. I didn't actually have a case of TB-delayed hypersensitivity uveitis since I left England, but we saw TB serpiginous uveitis. We saw lots of. We have syphilitic patients who we treat as well with Ozurdex after anti-syphilis treatment. I didn't treat any one of them with Iluvian, but Iluvian can be as well. So I have a couple of patients with persistent macular edema where they get Ozurdex now with Iluvian there. We can consider that as well. I don't see any problem treating infections as long as the infection treatment has been given. Yeah, I agree.
Well, if we've treated their TB and they've been lasered in the non-perfused area and the ischemic drive is presumably switched off, why do they keep getting this macular edema, which is so steroid responsive?
I think it's like the syphilitic patients as well. They keep getting macular edema in the absence of recurrences or reactivation. It just their immune system gets, I think, affected by the infection, and they just continue to get. Also, there might be it's also the blood retinal barrier has an insult, so there's no like active inflammatory drive, but just the retinal barrier is weak.
Do you have any comment, Dr. Richard, about this?
I think when we are talking about infections, it's very important, not for you guys, but for the other people, to be very careful. There is no active infection, number one. And second, in TB in particular, there are two types of TB. One is multiple, like what Hassan was showing. You have those huge granulomas, subretinal abscess. Don't give local injection in those circumstances. But if you have the vasculitis, the immune-mediated response where you are not expecting any bacteria to be multiplying in the eye and you have given treatment for infection, here it can be used very nicely instead of systemic.
But still, you have to keep covering with the anti-tuberculosis at that time, right?
Absolutely. Have to,
Yeah, you treat them for the TB, yeah. So it's not the first. I mean, you have to give the TB treatment, and again, what I don't like is where some people give the TB prophylaxis, and these patients need full TB treatment.
that increases the chances of drug resistance.
Yeah.
Okay, so again, just a quick case number 3. This lady came to me, this 36-year-old school teacher. She again was treated elsewhere for uveitis. Very upsetting case. So she came with her right eye. She was nearly blind with this huge detachment and a lot of scar tissue here. And really, this eye could not be salvaged. In the other eye, she had a pale disc and a lot of inflammation. She was pseudophakic, and again, never been immunosuppressed, which was a huge surprise to me. She was being treated, and for several years, but never been immunosuppressed. And so this was in 2016. So I started her on mycophenolate and gave her an Ozurdex, and her vision improved to 6/9 in that eye, in the left eye, and she couldn't believe it, and it was gratifying that she could improve, but really upsetting that she hadn't been immunosuppressed for so long. And so this was her left eye pre-treatment and then post-treatment. But again, she kept getting this a bit of macular edema, and her vision would fluctuate. I know there's this big epiretinal membrane, but seeing that she had this was her only eye, and it was quite a delicate situation. Her vision was not too bad; she was managing. But every time this sort of happened, her vision went from sort of 6/12, 6/9 to 6/12 to 6/18, and as a school teacher, she found it very difficult. So again, she kept having Ozurdex injections, and this was in September. And then she came back in December again with the 6/12 vision and a few more areas of cystoid change. And so I said, okay, why don't we try Alluvian? So I gave that to her in December, and then in January she improved, and then again I saw her in February. She's back to 6/9, and she was due to see me this week, but I think she postponed it due to the whole home learning situation that she, as a school teacher, has been overwhelmed with organizing online learning for her students. So again, very useful in this sort of situation and helps her. She's still on her mycophenolate, but it just means that she doesn't have to have that repeated injection. And of course, every time you flare up and you get fresh macular edema, it's possible that you're going to end up with some collateral damage, and that you keep things under control means that would be. So it's a good response to Iluvien here early on with a pretty good visual result. So, Iluvien can be pretty effective for the control of uveitis and uveitic macular edema. It can work quickly. Sometimes it doesn't. So it's important to say to your patients that, this can take up to 3 months. They're used to having Osidex, which works instantly. Osidex, you give it literally within a few days, patients do notice improvement. Iluvien can take a bit longer, but sometimes you'll be surprised that it will work quicker. It can last for a long time. I do say to the patients that you may require top-up treatment with another Osidex or an anti-VEGF, depends, along the course. But overall number of injections over the 3-year period should be less. May also be effective as monotherapy, not as an initial treatment, but once you've got control and the disease is subsided, you can consider monotherapy, as we saw with the first patient who stopped her systemic medication. It can be used as an adjunct to the systemic treatment, as we saw with the previous case, and reduces the need for these repeated injections and reduces the flare-ups as well. So another useful tool in our armamentarium, I think. So that's all I have to say. Just my experience with Iluvien over the last couple of years.
Thank you, Abi, for very interesting cases and showing how Iluvien work in uveitis in different situations. We have only one question. Does Iluvien has more impact on IOP than Ozurdex? It's for you.
The short answer is probably yes. And you would, but when you look at the studies, Iluvien compared to Retisert has a much reduced IOP raising profile, and again it tends to be temporary. So patients, you will monitor them. These are patients with uveitis, especially. They will be the ones who have pressure problems, either up or low or high, and you are going to monitor them, and they do respond to topical treatment reasonably well. The ones, the diabetic patients, when you look at them, does their pressure go up significantly? I don't think so. Compared to Osidex, it's pretty much similar.
Okay. Any experience with interferon for tubercular macular edema? This is for all the panels, if anyone wants to answer.
No, I don't have any experience.
Dishari, I think you have some.
I tried for paradoxical worsening. I tried in 4 patients. It worked for 1 patient, not good. I'm not too much.
Okay. There is a question. Please comment on anti-VEGF, anti-VEGF versus steroid injection for uveitic persistent macular edema.
So personally, I don't use anti-VEGF for uveitic macular edema. There was a trial done or study done. I think it was called the LEMO study, Lucentis in macular edema, which was stopped because it doesn't really work. It doesn't work, so I don't use anti-VEGF. Anti-VEGF is useful for many cases of uveitis where they have neovascularization, things thick, and for secondary CNV is extremely useful. But for macular edema, which is an inflammatory-driven process, no, I don't.
I think it's also evident that anti-VEGF works on a very specific part of the inflammation cascade, really, if it works on anything. Just on the VEGF, well, steroids have more than multiple mechanisms. It's just not enough.
I use VEGF if IOP is high and you don't want to give steroid injection. But currently we are doing this merit trial by Doug Jabs and all, where we are comparing methotrexate, Ozurdex, and this one, anti-VEGF. So let's see what that multi-center results show. But I agree, most of the time it's the steroid which works very well. But if the IOP is high, then we tend to give it.
But, Dr. Abichari, we are dealing with inflammation in case of uveitis. So maybe you are treating the edema in a certain limit, but in the general, do you think steroid is more better?
Yes.
So there is one question also, any advantage for Cellcept over methotrexate in the last case presented? Adi?
Conventionally, there was a study done by Nisha Acharya recently, and in conjunction with Dr. Rathinam in Arvind, and that I think most uveitis specialists were a little surprised with the results, and we found that methotrexate actually did better than mycophenolate in controlling uveitis, which when the uveitis specialists were surveyed, they felt that mycophenolate may be better. Which drug to use in which disease, I think most people will have a personal feel. I find that in things like anterior uveitis, scleritis, methotrexate works much better. In posterior uveitis, I find mycophenolate works better. But again, that is my anecdotal evidence. The trial done by Dr. Rathinam and Nisha showed that methotrexate and mycophenolate are pretty similar.
Thank you. Thanks, Adi. Okay, Dr. Bichari, can you prepare the question or raise hand? There is raise hand from Dr. Muhammad Shahid. Okay, Dr. Bichari, go ahead till he is ready.
Mycophenolate needs less of monitoring than methotrexate. It's easier to handle. But I think there is something to do with pharmacogenetics. It doesn't work in Indian population. So maybe that is why the results of that study were kind of, a surprise.
Sure.
Because when I worked in Riyadh, it used to work very well. When I came to India, it just doesn't work. So I don't know why.
Dr. Ari, can I put a quick comment on the question, does local treatment works compared to systemic treatment?
Okay.
I think good to look at the MUST trial, which looked at Retisert versus systemic treatment for non-infectious uveitis. If you look at the 3 years data, which is really interesting, where the Retisert was working, and that can be extrapolated on other local treatment, the results were the same for uveitis control and for vision. But then if you come and look at the extension of the study, the retrospective extension at 7 years, patients on systemic treatment did better. The reason is there was more adherence to treatment in the systemic group, and patients who had Retisert, a big number of them did not have another Retisert. So I think it's really, both work so well. We know that local treatment works better for macular edema, but it's all about systemic side effects versus local side effects and the adherence. So that's really an important point to keep in mind.
In practice, I use a combination of both.
Yes.
You would assist treatment because there are so many extraocular manifestations of uveitis which will not be taken care of by local therapy. But sometimes very high dose of systemic therapy to manage the acute exacerbations in between. Those can be handled by supplementing the local therapy. Low dose are the just adequate dose of systemic immunosuppression in the back.
Okay, can we have Dr. Muhammad Shahid? Dr. Muhammad, if you are there, can you please? Dr. Muhammad. John, Dr. Muhammad with us?
Yes, doc.
Okay, Dr. Muhammad, if you hear us, can you go ahead and ask or do your comment, please? Dr. Muhammad Shahid. Hello? I don't know, we lost him. I would like to thank you all. If there is any last comment or talk from any of panelists, Dr. Bichari, thank you very much for being with us. I know it's very late for you now. I think it's 1 o'clock. We are sorry for that, but we know there is a difference. Ahmad is still very happy because